Recording in progress.
그러니까 마이크 들리는 거지. 그냥 시작할까? Hello, everyone. I'm pleased to meet you, although it's online. During this course, we'll discuss Class 3 early orthodontic treatment. Your course was held in Vilnius, Lithuania, 2019. I went to Davis Museum. Caucasian considers facial asymmetry and Class 3 patients as devils. This kind of Class 3 malocclusion is one of the most common orthodontic problems, and it occurs in about 10% of the population. In Class 3 patients, we can see the aesthetically unpleasing profile. Many knows mu is effective in treating Class 3 malocclusion. Why? Why is the difference between conventional orthodontic treatment and mu technique? Mu technique is basically focused on the vertical problem, vertical dimension. So we consider vertical dimension, vertical problem can affect transverse problems and sagittal problem, especially in Class 2 and Class 3 midline deviation and any kind of malocclusion. As you know, this is aging and orthodontic treatment. So we can divide the orthodontic treatment into various groups depending on the age. Early orthodontic treatment, general orthodontic treatment, adult orthodontic treatment. Finally, we can see the full mouth rehabilitation. We can apply your concept to whole dentition. However, the new concept is something different from conventional orthodontics. So during this course, we focus on the early orthodontic treatment. These are parents' main concerns. When to start orthodontic treatment. Also, patient discomfort to the appliance or cost. However, these are main problems in early orthodontic treatment. It takes longer treatment duration. If we will start 6 years old or 8 years old, finally we'll check the 18 because the third molar eruption can affect class 3 malocclusion. The second is iatrogenic malocclusion can happen. If we decide, if we have some kind of wrong diagnosis, and then we can make different malocclusion. So this time, I will introduce class 3 malocclusion. First, normal growth and development. Second, class 3 deep bite versus class 3 open bite. Third, over eruption of the lower incisors. And long face versus short face, posterior crossbite, and also primary canine relation and first molar relation, and upper anterior crowding and lower anterior spacing. And finally, we should classify class 3 malocclusion. What happened in normal growth and development? You should remember two things. First, increase in vertical dimension. Second, mandibular forward movement growth. At first, we can see the maxillary growth, and then we can see the mandibular growth. Regarding increasing in vertical dimension, which one is better? Short face is, we can see the favorable response. However, in long face patient, and then you can see the achieve unfavorable response. And also, regarding mandibular forward growth, class 2 patient, it is okay. However, in class 3 patient, it may worsen. So we can see the high chance of worsening anterior crossbite. If we can see 6 years old and 8 years old, 10 years old, we can see the similar anterior crossbite. However, the younger patient and the more severe class 3 malocclusion. Second factor, we should check class 3 open bite versus class 3 deep bite. Rules. Class 3 deep bite, you can see the severe anterior crossbite. However, in this case, moving the lower jaw backward, and then we can achieve easier treatment. However, in class 3 open bite, the patient already has the long face. So it is not easy to increase vertical dimension. In class 3 malocclusion, which one is more popular, open bite or deep bite? We can see the different view. In adult patient, and we can see class 3 open bite, some kind of edge bite. However, during the primary and mixed dentition patient, and we can see the class 3 deep bite. This kind of class 3 deep bite looks severe. Third factor, you should check the over-eruption of the lower incisor in class 3. It is similar to class 2 division 2 malocclusion. In class 3 malocclusion, and you can see this over-eruption of the and lingual version of the lower incisor, and we can see the excessive curve of P in the lower arch. And finally, the maxilla cannot grow forward. So we can see the class 3 malocclusion. Fourth, backward movement of the mandible. You can see this is an edentulous patient, and then you can see the class 3 profile. When we insert denture, and then we can see the nice profile and increasing vertical dimension. So in class 3 patient, especially in class 3 deep bite case and increasing vertical dimension, this means, and the lower jaw backward and posterior. And this kind of movement is good for class 3 treatment. So if the patient has the leukofacial type, it is difficult, not easy, and unfavorable response. On the other hand, brachyfacial type, and it is not difficult, and also we can achieve favorable treatment response. So we should assess this type of malocclusion. There are two things. First, facial aesthetics, and second is cephalometric radiograph. As you know, a newborn is baby. A newborn is born. Newborn is looks class 2 profile. However, growth and development, and then the patient, this child and change class 2 or class 3 profile. So you should decide which one is better, facial aesthetic and cephalometric radiograph. We should assess the class 3 malocclusion. This is anterior posterior. We need differentiate sagittal problem. So there are lots of methods to evaluate the sagittal problem. Somebody use A and B, width appraisal, APDI, AB plane angle. This is wardrobe research. What is it that a particular cephalometric measurement is supposed to diagnose? How do we determine whether the measurement is a reliable and valid test for its intended purpose? Thus far, the best method for determining the validity of a diagnostic measure is ROC analysis. So ROC analysis consists of sensitivity and specificity. Looks A and B, which measurement is more accurate? B is more accurate. So compared to A and B, the closer the curve follows the left-hand border, and then the top borders of the ROC space, the more accurate the test. So B is more accurate than A measurement. And Dr. Han researched the result of this study indicated that anterior-posterior dysplasia indicator shortened APDI, have the best diagnostic ability in identifying cases with class 2 and class 3 skeletal patterns. So APDI is the best. What is APDI? APDI consists of the sum of three angles: facial angle, AB plane angle, parietal plane angle. So this angle is a parietal plane. This is AB plane. So this is the same value of this angle. We call this is AB, maxillomandibular triangle. At that time, lesser than 17.7. This means class 2 skeletal pattern. Greater than 85 means class 3 skeletal pattern. This is Dr. Young Kim's paper and APDI value in Caucasian and the Chinese, Japanese, Korean, and the mean value is 81. You should remember this. 81 is normal value. And greater than 85 mean class 3 tendency, especially greater than 89. This is skeletal class 3. So the greater APDI value, the more severe class 3 malocclusion. And second factor is ODI. ODI is the sum of AB2 mandibular plane angle plus parietal plane angle. So this angle. However, you should remember this and combination factor. Combination factor is the sum of ODI and APDI. The normal value is 155. However, in class 3, low angle mean is greater than 160. So greater than 160 in class 3, this means low angle. We should do non-extraction. If lesser than 150, this is high angle, so we need to extract some teeth. So these are anterior crossbite and class 3 malocclusion. I want to divide the class 3 malocclusion into dental-alveolar class 3 or skeletal class 3 malocclusion. Dental-alveolar class 3 malocclusion is the skeletal pattern is class 1 or class 2. However, skeletal class 3 malocclusion has skeletal class 3 skeleton. And we should divide class 3 high angle and class 3 low angle. Class 3 open bite is closely related with class 3 high angle case. And also class 3 deep bite is closely related with class 3 low angle case. There is a high chance of severe class 3 malocclusion in younger patients, even though the similar value of APDI because of mandibular forward growth. This patient is 8 years old. However, upper patient, you can see the APDI 86. Low patient is 92. Which one is severe? 92 is severe. Fifth, you should check posterior crossbite. In class 3 malocclusion, we can also see posterior crossbite, and also you should check narrow upper arch. How can we measure the narrow upper arch? This is TPW, transpalatal width. As you know, this is Dr. McNamara paper, and then especially after eruption of the upper tooth number 6, this distance is increasing until 35. Especially when we treat the early orthodontic treatment, early orthodontic patient, and we should check the age 8 to 10. At that time, you should remember the normal transpalatal width is 33. And his report, and if the TPW, the initial value is lesser than 31 millimeter, how about the value of the TPW in the 15 years old, 32? So it's mean and not sufficient to grow in low value of TPW. What happened in narrow upper arch? You should remember, you can see the 3 types of malocclusion. First, class 3 malocclusion, and midline deviation, and also class 2 malocclusion. However, at first, you should think class 3 malocclusion. 6, we should check primary canine relation. This is upper deciduous canine and lower canine. This is class 1 canine. How about this patient? You can see the class 3 canine. During the growth and development stage, and then the lower jaw move forward more and more. And also, we should check the crossbite of the primary canine. And also, we should check the molar relationship. As you know, this is a flush terminal plane. Before eruption of the first molar, we should check the terminal plane, this area. So this is a flush terminal plane and distal step and medial step. This is my data, and then we should check during the growth and development. As you know, this is class 3 medial step. What happened? Difficult to achieve class 1. Maybe this medial step can change into half class 3 or full class 3 malocclusion. So when you check primary canine, we should check the 3 stage, anterior posterior relation. So class 1 is okay. In class 3, this patient, you should remember, this patient may have class 3 problem. And also regarding transverse relation, if there is a crossbite, we need expansion. And also some patient, we can see the shape of the primary canine, where condition is okay. However, you can see some patient pointed primary canine. You should grind this area. 7, first molar relation. We all know this. Eight factor, upper anterior crowding. in class 3 malocclusion, and we can see some patient, we can see the no crowding and also severe crowding or mild and moderate crowding. What happens if treating anterior crowding without extraction treatment? If there is a upper anterior crowding, we can resolve this crowding without labial version of upper incisor. On the other hand, if there is a crowding in the lower arch, not easy to resolve this crowding without labial version. This patient, there is no slight crowding in the lower arch. However, you can see the upper anterior crowding. So this means if there is an upper anterior crowding, we can achieve non-extraction treatment. On the other hand, if there is a lower anterior crowding, we need to extract some teeth. So difficult to achieve the in this patient, difficult to achieve and without extraction treatment, it is not easy. In class 3 patient, and this patient there is no crowding in the lower arch. However, in the upper arch, we can see some crowding. Some case we can see some slight anterior crowding in the lower arch. However, in the upper arch, we can see severe anterior crowding. This is lower anterior spacing. You should check the lower anterior spacing is normal or abnormal. Upper anterior spacing is normal. As you know, this is ugly duckling stage in the upper anterior spacing. However, in the lower anterior spacing is abnormal. In this, if there is a spacing in this area, what happens? Patient may thrust tongue this space area. So this is called passive tongue thrusting heavy. So if there is a space in the lower arch and the patient may thrust the tongue forward, it means, and then it may worsen the class 3 malocclusion. So if there is a space in the lower arch, we should close the space. The closing the space in the lower arch is good for class 3 treatment. So we should classify the class 3 malocclusion. However, I want to classification based on the treatment difficulty. When we treat the class 3 malocclusion, we want to divide class 3, so undergrowth or posterior position of the maxilla or overgrowth and anterior position of mandible. And also, we should divide the class 3 into dental alveolar class 3 and also skeletal class 3 malocclusion. Dental alveolar class 3, I want to divide two groups. The functional class 3. Second factor is dental class 3. In this group is skeleton is class 1 or class 2. APDI, so APDI value is lesser than 85. And on the other hand, skeletal class 3, I want to this group into class 3 low angle and class 3 high angle. And before then, and you can see single tooth crossbite, especially in the maxillary central incisor area. And also we can see in the maxillary lateral incisor areas. And this is, as you know, this is a functional class 3. You can see lingual version of upper incisors and labial versions of lower incisor. So mandible may move forward. So this functional class 3 malocclusion, usually you can see class 1 low angle skeletal pattern. Class 1 mean anterior posterior relation is normal. Low angle mean is the brachyfacial facial type. In cephalometric radiograph, and then APDI value is lesser than 85. Combination factor is greater than 155. In this type of class 3 malocclusion, we can see anterior crossbite with or without deep bite, and lingual version of upper incisors, labial versions of lower incisor. At that time, it is possible to make H to H bite. What's the cause of functional class 3 malocclusion? Especially in edentulous patient, and there are multiple missing cases, and we can see posterior bite collapse. However, during the primary or mixed dentition period, I want to emphasize this: collapse of maxillary anterior dental perimeter, over eruption of the lower incisors, lower anterior spacing. This is normal eruption pathway of the upper incisors. The maxillary central incisors are erupting at the palatal side and in the greater labial side. So finally, we can see the smaller inter-incisor angle. So these are main cause of collapse of maxillary anterior dental perimeter. A, the palatal eruption of the upper incisors. So some case, and we can see prolonged retention of deciduous incisors. And also we can see upper anterior crowding. See some case, we can see severe decayed teeth. D, premature loss of upper anterior area. So as a result, upper incisor positioned posteriorly. And also we can see E, small upper lateral incisors, and or missing on upper lateral incisors. And also we should check the lower anterior spacing. This you should remember, this is abnormal situation. Second group is dental class 3. Dental class 3 is class 3 high angle skeletal pattern. This means anterior posterior relation is normal. However, high angle means the mandibular plane angle is steep, greater value. So this means is a dolichofacial facial pattern. In this patient, APDI value is lesser than 85, and combination factor is lesser than 150. This patient, because of the steep and retrognathic mandible and what happened in the teeth, we can see mesial angulation of the teeth. So in anterior area, and we can see anterior crossbite. So anterior crossbite with or without open bite. And this patient show retrognathic mandible and steep mandibular plane angle. Some case we can see the lack of curve of sphere or crowding. This patient has high possibility of high angle skeletal class 3 malocclusion during the growth and development. See, this is a skeletal class 3. As you know, this is skeletal skeletal problem is on the development of the maxilla and prognathic mandible. So upper incisors and normal inclination or labial version, or lower incisors, normal inclination or lingual version to compensate the anterior area. In this type of malocclusion, and it is not easy to make edge to edge bite. In this skeletal class 3 malocclusion, we should divide two groups, class 3 low angle, class 3 high angle. This is class 3 high angle class 3. This is low angle class 3. What happened? There is difference between the mandibular plane and mandibular response. High angle class 3 means APDI value is greater than 85 and combination factor is lesser than 155. On the other hand, low angle class 3 combination factor is greater than 160. Today's second class, I want to discuss etiology factors of class 3 malocclusion. The first thing you should remember is in class 3, the first thing is over-eruption of the upper molar. In high-angle class 3 malocclusion, what happened? You can see flat occlusal plane due to molar over-eruption. In the lower incisor area, you can see lingual version of lower incisor. So this means is dental compensation. And lack of posterior vertical dimension and long lower anterior facial height, steep mandibular plane. So this means, and we can see mesial angulation of the lower molars. So you can see some patient steep POP. So in class 3 high angle case, molar over eruption, and as a result, we can see for the position of the mandible. So ODI value is lower, FPDI value is greater, and CF value is lower. This is low angle class 3. It's the same. The first thing you should remember is over eruption of the upper molar. However, the mandible move forward a lot. So this is auto-rotation of the mandible. In this patient, and we can see the posterior rotation of the maxilla. This means the parietal plane angle is positive value. This patient, and we can see dental decompensation. In class 3 malocclusion, we should think in class 3 and lingoversion of the low incisor. However, this patient, labial version of the low incisors. And also we can see the sufficient posterior vertical dimension in an average or flat mandibular plane and flat or normal POP. So molar over eruption and the mandible, the forward rotation of the mandible. So ODI value is lower. However, FPDI value is greater than class 3 high angle case. CF value is greater. In these two groups, the treatment strategy is different. In low angle class 3 patient, and the treatment strategy is first, increase vertical dimension. If there is a class 3 deep bite case, and then through increasing vertical dimension, and we can achieve good profile, and also we can see mandibular opening, and then we can achieve good this interdigitation premolar and molar area. You should remember this increased vertical dimension is a key to treat low angle class 3. However, high angle, what happened? What's the treatment strategy in high angle class 3? So in this group, we should extract some teeth to resolve the posterior discrepancy. And also, we should do occlusal plane control. Some case we need surgery. So I want to divide this class 3, another group, class 3 subdivision. Class 3 subdivision mean and once full or half class 3 in one side, and the other side is class 1. So midline deviate to the class 1 side. So this type has overgrowth of the mandible, especially in the unilateral side. Also, the patient's skeletal pattern is class 3. This means FPDI is greater than 85. This patient is right side half class 3. Left side, this is upper canine, lower canine, half class 2. So as you know, this is a dental alveolar class 3. The functional class 3 and dental class 3 and skeletal class 3. It may develop the same functional class 3 and dental class 3 and skeletal class 3. Especially in functional class 3 and dental class 3, these malocclusion changed the transitional class 3 and finally and may change skeletal class 3 and functional class 3 change in the low angle class 3. In dental class 3 changed high angle class 3. If you evaluate the this is ODI value, this is APDI value, this is a combination factor. So you should remember this second value, 87. So greater than 85, this means is class 3. Combination factor is 148. So lesser than 155, this means class 3 high angle case. This means is mandible moved forward and backward, moved forward and downward. The patient has a dolichofacial type and class 3 open bite and class 3 high angle. In this case, we can see complicated case. On the other hand, this patient, APDI value is 100, severe. Combination factor is 161, greater than 160, and then class 3 low angle. So mandible move forward and upward. So this patient shows brachyfacial type and class 3 deep bite and class 3 low angle. This patient is relatively mild case, milder than class 3 high angle case. So I want to divide this malocclusion based on the treatment difficulty. Functional class 3, dental class 3. So this is dental alveolar class 3. This is simple case in Mio technique. And especially, I want to divide 3 groups: simple, complex, complicated. So class 3 subdivision. So this is midline deviated to the other side. And also class 3 high angle case, and then somewhat complicated case. And also class 3 low angle case looks severe. However, this is complex case. This is mandibular plane. This is AB plane. This is palatal plane. So this value is ODI. This value is APDI. Even though the patient has those similar value, however, what happened in class 3 low angle case, the mandible positioned more anteriorly. So this means the severe class 3 malocclusion in low angle class 3 case. This is Korean Professor Dr. Zhang's report. The predictable relapse in early orthodontic or orthopedic treatment of class 3 malocclusion. He wants to divide 3 groups according to the status of occlusion in the retention period. The good stability. Second group is fair stability, and third group is relapse group. The conclusion is AB2 mandibular plane angle proved to be an efficient indicator of relapse. This is AB plane, mandibular plane, greater than 65. This is good prognosis. On the other hand, lesser than 65 mean poor prognosis. You can see this is a red line. At that time, treatment may be postponed until the end of the cross period. What does it mean if the AB2 mandibular plane angle is lesser than 65? High angle class 3, high angle class 3 open by case. Second group is severe anterior posterior dysplasia, severe class 3 malocclusion. Especially you should remember this. In high angle class 3, if we want to treat this kind of malocclusion in the child, however, if the AB2 mandibular plane value is lesser than 65, the treatment prognosis is not good. So this is some summary. This in some cases we can say single tooth crossbite. This is a simple case, and the treatment timing start early. And class 3 deep bite case. You can see most cases in class 3 malocclusion in this early orthodontic period. In high angle case, simple. It is easier. In low angle case, it's simple to complex and start earlier. On the other hand, class 3 open bite case. This is rare. And also this is a somewhat complicated case. So the deeper the anterior overbite, the more severe the anterior crossbite, and the easier the treatment. So when you treat the class 3 malocclusion, these are thinking process. The first, you should check the age and sex. Second, you should remember this, over-eruption of the upper molar. And aesthetic. And also, first factor is a skeletal pattern. Skeletal pattern, at that time, you should do APDI first. The second factor is a combination factor. Many knows that ODI value, however, combination factor value is more effective than ODI value. So we want to divide low angle class 3 and high angle class 3. And finally, we should check the denture pattern. At that time, the primary canine relation and molar relation and upper anterior crowding and upper incisor and lower incisor position, and also lower anterior spacing. So at that time, I want to gather the data like this. As you know, this is a panorama radiograph and SAP, lateral and PA, and periapical intraoral radiograph in the upper anterior area, and facial and intraoral photos and model. So we should analyze these data. So this sheet is a cephalometric analysis sheet for early orthodontic treatment. It consists of these factors: symmetry analysis, anterior-posterior analysis, vertical analysis, incisor analysis, occlusal plane analysis, aesthetic analysis. So first, midline and ramus height and antagonal notch. So you should check the symmetry or asymmetry relation. And next part is skeletal class 3 or dental class 3. And also the upper incisor position, lingual version, and or normal or labial version. And also we should check the lower incisor position. You can see this patient. We can see the anterior crossbite. This patient is maybe 8 years old male patient, boy patient, and you can see anterior crossbite. And also you should check there is a space in the lower arch. Right there. So this is sheet. So midline is a match. Ramus height is okay. Antagonal symmetry is okay. If there is a asymmetry in this age area, it may worsen during the growth. ODI 62, APDI 85, combination factor 147. This patient, class 3 high angle patient. So next step is ODI. And fifth, APDI and CF. So we want to easily and assess the skeletal pattern. And FMA. FMA is mandibular plane angle. Through this, and then we can see this. This patient is a skeletal class 3 malocclusion. And next group is I want to check the dental part. Upper to rim line, UOP. And upper one to inside FH angle, lower to mandibular plane angle, interincisor angle. So in upper incisor, you can see lingual version of the upper incisors. And also normal angulation in the lower incisor. And next step is edge-to-edge profile, acceptable. So during the treatment plan, so I want to check this. In order to treat class 3 malocclusion, and then the maxilla should move forward. Some case, maxillary dentition should move forward, and we need some case lateral expansion. And third part is mandibular dentition backward, and fourth factor, mandible backward. So at that time, these are checkpoint. So I want to check edge-to-edge profile and a point to Nesium perpendicular line. So this means -2 millimeter mean. A point is posterior position. Upon to FH 108 is lingual version of the upper incisor. Lower to mandibular plane 92 is normal. And lower anterior space, there is a space. Deep bite is better. However, this patient is maybe edge bite. Combination factor is lesser. Next week, I will discuss differential diagnosis in detail. This patient, 8 years old girl, and you can see anterior crossbite. Her mother is also class 3 patient. There is no crowding in the lower arch. There is a slight mild crowding in the upper arch. Midline, Ramos height symmetry and antagonal arch symmetry. ODI 68, APDI 90. Combination factor is 159, class 3 low angle. However, this patient, and we can see the enlarged palatine tonsil. This patient has skeletal class 3 malocclusion and normal angulation of the upper incisors and normal angulation of lower incisor. This patient is 8.2 lesion perpendicular is -1 millimeter. And we can see slight, there is a posterior crossbite this area. The other value is almost normal. This is the first lecture in this course, and then I want to introduce the class 3 malocclusion. This is coffee break. This is my hospital. So I built my building in 2002, 20 years ago. This is a 8th-floor building. This is a 7th floor. This is my room. So nowadays I'm taking this video, this area. The second floor is the orthodontic department. Okay, and let's take a 10-minute coffee break. Okay. Okay, let's move on to another topic, etiologic factors and treatment to strategy in classroom occlusion. How can we treat this kind of classroom occlusion? These are common treatment modalities of anterior crossbite. Distalization of or limiting the forward growth of the mandible. Second, forward movement of the maxilla. And lower molar distalization, forward movement of the upper incisors, and distal movement of lower incisors. In order to achieve this, many orthodontists use mini screw or of a second premolar and lower first premolar extraction, in some case, orthodontic surgery. So this method focused on the anterior posterior problems. What do you think of the causes of class-3 malocclusion? Genetic or environmental problem? Some orthodontists consider this patient has some enlarged adenoid and palatine tonsil and lower tongue position. So some think class 3, some think this kind of malocclusion may be caused by environmental factor, especially in airway problem. However, if there is no or mild environmental problem, how can we think the etiology of class 3 malocclusion, skeletal or dental? These are high angle open bite versus low angle deep bite case. This is a vertical problem or vertical relation. It depends on the muscle activity. And on the other hand, in sagittal relation in class 3, class 2, class 1, and many consider cranial base angle as the main cause. So malocclusion are from genetic origin. Is that all? when a baby is born and then finally this baby changed class 2 or class 3. Especially in age 6 or 10, this area, if you consider this kind of class 3 metaculum from genetic origin, how can we treat? Surgery. So many consider class 3 metaculum as a causative factor from genetic. However, difficult to decide the surgery treatment. So at that time, we recommend the patient dental camouflage treatment in class 3 malocclusion. So this means upper second premolar and lower first premolar extraction and or lower first premolar extraction. This is a severe class 3 or class 2 malocclusion. The major deviation is from the genetic origin, but most of the deviation within normal phase is dependent upon the environmental factors, this area. So as you know, this is cranial base angle. So somebody use this nasion, cellular, or articular, articulare, or Bayesian. At that time, you should check the mandibular condyle is changeable or unchangeable structure. As you know, this is condylar growth. What is difference between A and B? Looks similar, however, totally different. In figure A, and the condyle grow spontaneously. So this is called primarily grow primarily. On the other hand, this in figure B, and then in some condition, some situation, the condyle may grow. So this means in picture A, the condyle is unchangeable structure. On the other hand, in picture B, and the condyle changeable structure. If you consider A, and maybe we need surgical treatment, how about B? In normal science, and then this is paradigm. Paradigms encompasses theories, which in turn encompass hypothesis. This hypothesis is based on the significant fact. In T1 stage, this paradigm is always changing between normal science and a scientific revolution. In T1 stage, paradigm 1 was the general mainstream, but over time, the paradigm 2 began to gain support from the community that favored in paradigm 1. And gradually, the paradigm 2 is becoming normal. And finally, in T4 stage, the paradigm 2 is the mainstream. So as you know, this is paradigm shift. What does it mean in craniofacial biology? In 1940, all skeletal tissue are from genetics. In 1950, and as you know this, if there is a there is a loss of tooth, and you can see some change. So periosteum and suture is not from genetic origin. In 1960, nasal septum, cranial base, mandibular condyle are from genetic origin. Among them, the mandibular condyle is the problem or some issue. And finally, in 1990, nasal septum and cranial base are from genetic origin. So this means, so craniofacial complex is highly adaptable structure. So this is mandibular advancement and condylar adaptation research. Anterior part, posterior part, middle part. And they researched the adult rat. Adult rat is, we consider no growth. However, compared to control group and then in the experimental group, and then we can see there's enough growth. Like this. In 1975, Dr. Graeber told this. When there is a pressure in the condyle, this is called loaded, like chinker, and less and no growth in the condyle area. On the other hand, in some case, unload. Unload means is there is some space in the between glenoid fossa and condyle. And condyle may grow. This is called unload. So, and nowadays the main concept is for condylar growth is secondary factor, secondary growth site. So this means condylar growth, condyle is changeable structure. And which factor may affect the condyle change? This is primate, and you can see that there is no class 2 and class 3 malocclusion, only class 1. However, in human, and we can see class 2, class 1, and class 3 profile and malocclusion. And so in human facial complex, we can see wide variations. So as you know, this is primate, and this is human, and uprighting of the body, and as a result, and also the skull is uprighting like this. So this means the craniofacial growth is vertically. This is the primate skull, and then the growth direction of maxilla is forward. On the other hand, in human skull, the growth direction of maxilla is vertically. So in human, and then so decreased vertical dimension and steep occlusal plane was seen. When a newborn, and you can see the 60% of neurocranium in the lower jaw and maybe 30% of viscerocranium. So this means, and maybe severe class 2 metaocclusion. In this metaocclusion, and we can see insufficient for vertical dimension, and steep occlusal plane and DPO. DPO is, this is occlusal plane, the distance, no DPO distance. In class 2 baby, it grow, and then, so some case, and then we can see class 2. So this means they fail to become class 1. On the other hand, in class 3, mandible adapts to march forward. This is a normal growing subject. And we can see the vertical growth of in the posterior part. How about the occlusal plane? Occlusal plane is lower value. This means flat. So these are alteration of occlusal plane and mandibular adaptation. I already mentioned that the condyle is changeable structure. So the first thing is adaptational reaction of the mandible to vertical dimension. So as a result, then we can see the secondary growth of the condyle. So class 3 metaocclusion is sagittal problem. So we want to divide two factors, maxillary retrusion or mandibular prognathism. And also we can check the vertical problem. Vertical problem is from dental factor. Dental factor is vertical dimension and occlusal plane and over eruption and upper and lower molars. And also we can check the transverse problem. So we can see the narrow upper arch or wide lower arch. As you know, this is a Schneemann growth curve. This is normal growth and development. The maxillary, we can see the maxillary growth first, and then later mandibular growth. However, in some case, in class 3 patient, if there is less sufficient maxillary growth, so what happened? If the mandibular growth is normal, however, we can see the class 3. So this is normal growth and development in transverse dimension. Maxillary growth first, and then through mandibular growth, and then we can fit perfectly in the between upper and lower arch. However, in class 3, maxillary growth first, but undergrowth, and then mandibular growth or overgrowth. So we can see the crossbite condition. So these are main causes of mandibular protrusion: the developmental deficiency of nasal cavity and deep palate, and narrow dental arch of the maxilla, and occlusal interferences, and class 3 metaocclusion. As you know this, however, what is the vertical factor, vertical relation related to the class 3 malocclusion. This is anterior part. Anterior parts consist maxillary growth, maxillary molar growth, mandibular molar growth, mandibular growth. On the other hand, this is posterior part. Posterior part consists of condylar growth and glenoid fossa growth. So if there is a balance between anterior and posterior part, the lower jaw grow well according to the y-axis. However, if the anterior part exceeds the posterior part, what happened? We have learned like that. Especially in the over eruption of upper molars, and this is a greater value, this area, and lower jaw is moving backward, so we can see class 2 malocclusion. On the other hand, anterior part, the posterior part is greater than anterior part. So this means, especially in the under eruption of upper molars, and it may cause class 3 malocclusion. So in conventional orthodontics, especially in class 3 deep bite case, how can we treat this patient? In order to extrude the upper molar, so these are molar height and malocclusions in conventional orthodontics. In under eruption of the upper molars, we can see class 3 malocclusion and deep bite. Is that all? In this case, there is no exploration about the etiology factors, and then, so finally, in class 3 patient, recommended surgical treatment. So in myo-orthodontic, we should think outside the box. So extrusion of upper molar. Extrusion of upper molar, what does it mean? This value. This value is lower, and this is flattened occlusal plane, counterclockwise rotation of occlusal plane, like this. In conventional orthodontics, it may cause class 2 malocclusion. However, we should think again from the normal growth and development during this time, and then, so increasing posterior vertical height, this means molar over eruption. As a result, we can see the mandibular adaptation to forward. At first, so molar over eruption can cause hyperdivergency. This means is increased vertical dimension. At that time, if the patient sees the rib properly, the mandibular adaptation to the increasing of vertical dimension depends on the function of anterior mimic muscle. So it depends on the lip seal. This is FH and occlusal plane angle, FH mandibular plane angle. So during the normal growth and development, extrusion of upper molar, this means this value is lower. This means flat. So occlusal plane gradually decreases due to the extrusion of upper molar. And mandibular plane angle also decreases with age. But AB2 occlusal plane angle doesn't change. So maintain 90 degrees. So this means and low jaw is moving forward. So in conventional orthodontics, extrusion of upper molar may cause class 2 or open bite. On the other hand, in neo-orthodontics, extrusion of upper molar may cause open bite and class 3 malocclusion. In the first lecture, I emphasized this. When you think of class 3 malocclusion, the over eruption of the upper molar is the main causes. When regarding the vertical dimension, you should divide two factors. This is anterior vertical dimension. Another factor is posterior vertical dimension. Many orthodontists focus on the anterior vertical dimension. However, in Myo, we are focusing on the posterior vertical dimension. What is difference between class 3 and class 2 malocclusion? This is posterior vertical dimension is red arrowhead. Which one is sufficient? Class 3. On the other hand, this is occlusal plane. Which one is flat? In class 3 is flat. So in orthodontics, we focus on the vertical dimension and malocclusion. In class 3 and deep bite, we can see flat POP. So this means increased posterior vertical dimension and also decreased, some case, anterior vertical dimension. And later, through change in vertical dimension, and we can easily differentiate midline deviation cases. Dr. Professor Sato said in 1994, the posterior discrepancy is an important etiologic factor in the development of skeletal class 3 malocclusion because it affects the occlusal plane. At that time, many considered class 3 as genetic origin. However, he emphasized the dental factor, posterior discrepancy, is the main cause of skeletal class 3 malocclusion. This is a longitudinal growth sample of class 3 and extrusion of upper molar and flat mandibular plane. As a result, you can see the prognostic chin. Posterior discrepancy, and then so we should divide this. This is anterior discrepancy. This is posterior discrepance. Posterior discrepance is the proximal medial surface of the upper first molar, and then we want to check that this is PNS. In class 3, there is a smaller anterior posterior dimension of the maxilla because of the smaller maxilla dimension. And this means in order to erupt upper second and third molar, and there is no space, this means high chance of posterior discrepancy. The late Dr. Young Kim called this is posterior crowding. Is similar to similar word, okay? So this is a main developmental process of the skeletal class 3 malocclusion. The first, the over-eruption of the molars, especially in upper molar, occurring in skeletal class 3 malocclusion is due to squeezing out effect of a posterior discrepancy. The posterior discrepancy, which causes the over-eruption of molars, is a primary factor in the etiology of a skeletal class 3 malocclusion. What happened in molar over-eruption? There are two kinds of malocclusion. First, a mandibular forward rotation followed by condylar growth with continuous forward displacement of the mandible. If the patient is in the growing stage, this means class 3 malocclusion. Second, the appearance of an anterior open bite. If the patient's mandible cannot adapt to the new occlusal configuration, this is anterior open bite. What happened? The over-eruption in upper molar. So this means in decrease in occlusal plane angle. So there is an interference in this area. And we can see mandibular forward movement. This means class 3. And also, there is a limitation of maxillary forward movement because of due to the interference this area. And also we can see some class 3 profile. And also we can apply this concept to class 2 malocclusion. Extrusion of lower molar. This means increase in occlusal plane angle. So as a result, we can see maxillary forward movement and limitation of mandibular forward movement. So we can see class 2 malocclusion like this. This is my data. In dental classification, I want to check the class 1, 2, 3 malocclusion and upper molar extrusion and lower molar extrusion. In dental classification, there is no significant difference. But in the skeletal classification group, I did. Class 2 skeletal group showed a significantly higher eruption of the lower first molar in the stage of beginning of Hellman dental A3B and end of 3B, like this. On the other hand, in class 3 skeletal group showed a significantly higher eruption of the upper first molar in the final stage of dental growth. So over eruption of the lower molar mean like this. This is called steep occlusal plane. On the other hand, over eruption of the upper molar, the value is lower, decreases. So this is a flat occlusal plane. And you should remember this for treating class 3 malocclusion. So you should control the eruption of the upper first molar. And also, in skeletal group, stripper POP in class 2. On the other hand, in class 3, flat POP. POP means the cusp tip of the lower second premolar to this is the buccal cusp tip of the lower second molar. However, in the early orthodontic treatment patient, in early orthodontic patient, there is unerupted lower second molar. So we do not measure this angle. So what causes class 3 malocclusion? A, this is a posterior discrepance. So B, as a result, we can see over eruption of upper first molar. This means the occlusal plane flattening. As a result, mandibular forward movement like that. So as a result, the condyle grows forward. So as a result, finally, the class 3 may worsen more and more. So I think these are main class 3 etiologic factors. First thing, extrusion of upper molar. Second, increased posterior vertical dimension and or decreased anterior vertical dimension. Third, normal and flat POP. However, we should measure this angle after eruption of the lower second premolar. And fourth, flat EOP. And fifth, this coordinated arch. So how can we treat early orthodontic treatment in class 3 malocclusion? Intrusion of upper molar. Second, increase anterior vertical dimension. In order to decrease posterior vertical dimension, it is not easy through orthodontic treatment. Surgery can help to decrease posterior vertical dimension. However, increasing anterior vertical dimension is possible in class 3 malocclusion. Third, in order to make class 2 malocclusion over eruption of the lower molar, this is a key to class 2 development. So in order to treat class 3 malocclusion, we want to make class 2 malocclusion. First, coordination of arch. The first, intrusion of upper first molar. How can you achieve this? Somebody think hyperhead gear. However, it is not easy to apply this appliance in class 3 malocclusion to the class 3 malocclusion. And second is mule and mini screws. However, this appliance can be used for only after eruption of lower second molar. Another factor Another appliance is PBB. This is posterior bite block, shortened PBB. And transpalatal arch, TPA, shortened TPA. Second factor, the treatment strategy is to increase anterior vertical dimension. Following appliances can be used. First, anterior bite plate. However, this appliance can be used only class 1 and class 2 deep bite. It's difficult to use in class 3 malocclusion. On the other hand, PBB without anterior coverage, PBB or with anterior coverage, well, functional appliance. This factor is resin overlay. Resin overlay is, this is primary dentition, and then this is a resin cap, this area. Third method is extrusion of raw first molar. How can we achieve this? First, class 2 elastic. However, this patient is class 3 malocclusion. Second, ABP. Third appliance is utility arch wire. However, using utility arch wire may cause a labial version of low incisor. And fourth appliance is resin overlay. And also, in order to treat class 3 malocclusion, we should correct transverse problem. So some case we can see narrow upper arch, we may use expansion appliance. Some case in the widening low arch and we should constriction. However, it is not easy. At that time, I want to check transpalatal width and SNAP model analysis. SNAP model analysis is, even though this patient has anterior crossbite and after making normal over wide and over jet and class 1 canine key, I want to check the posterior relation. So some case, after making class 1, even though at first there is posterior crossbite, however, after making normal over jet, if there is no posterior crossbite, I do not use expansion appliance in the upper arch. When you use expansion appliance, and you may use RME or SME appliance. And also, so these are main cause of undergrowth of the maxilla. I already mentioned the over-eruption of the lower incisors. So as a result, we can see forward position of chin and overgrowth of posterior facial height and undergrowth of the maxilla. So you should check the over-eruption and control of the over-eruption of the lower incisor. So these are summary for treatment strategy for class 3 early orthodontic treatment. Among lots of appliance, and then we may use this kind of appliance or combination type of this kind of appliance. in order to increase anterior vertical dimension, PVB or region overlay. Intrusion of the upper first molar and PVB or TPA. Third, in order to extrude lower first molar, we may use region overlay on the lower second premolar. Also, in order to correct transverse problem, we may use expansion appliance. So during this course, and then you will learn some how to treat class 3 patient. So something you learn during this course may go against what you have learned from conventional orthodontics. And next week, we'll discuss transpalatal with arch and region overlay. And on the 5th of April, and we should discuss differential diagnosis in class 3 malocclusion, and also maxillary and mandibular dental problems. And the rest, 22nd of the April, we'll discuss skeletal class 3 problem and face mask, and also face mask and fixed appliance treatment. Okay. Thank you for your attention and see you next week. If do you have a question and leave a message to us, okay? 그다음에 어떻게 되지 뭐. Okay, bye bye.